So this is a very interesting program today. It's different than something that I've done previously, and I think for many of our speakers as well. And let me just move forward here. What's different about it is that most of us normally speak to medical audiences, and I know there are some physicians who are on watching this today, but a lot of you are not in the medical field or the healthcare field. And you're really our main target audience for this. Why are we here? Well, we're here because, let's see if I can advance this. There we go. Because we want to share with you what, as Himanshu just said, what really should be a major story in healthcare for men that's been under-recognized, maybe even unrecognized for far too long. And there's two parts to it. One is that men, as they get older, and sometimes for other reasons, for health reasons, can develop lower levels of testosterone, which we call testosterone deficiency. And what you're going to hear today in the program is about the impact of testosterone deficiency on men. And its impact is huge. And we have the highest level evidence, much of which will be presented to you, about all the different ways in which testosterone can be beneficial. So our goal is to hopefully impress you with some of that, maybe provoke you to think differently about it, and ultimately to be able to maybe help facilitate some action around this for the benefit of our patients, maybe yourself, and for those who we care about, and to some extent to society. That's what we're trying to do. And I've lost my ability to go forward. Here we go. Now, we have just an incredible set of speakers. All of them are internationally known. Many of them are really the cat's meow, if you will. They're all excellent speakers. The topics they've selected to talk about are important, and you're going to enjoy all of these presentations. How it's going to work is we're going to have 7 brief presentations. They're all 7 minutes in length. We're going to have 5 minutes Q&A for each of the speakers. And then we're going to open it up to the entire speaker panel at the end of those presentations. And we're going to be done by noon. A couple of things that just might be useful for you, especially if you're not in healthcare or in this field. There's some interchangeable terms. You're going to hear both of them. Of each of these. One is testosterone deficiency, is what is low level of testosterone, often accompanied or usually accompanied by symptoms. And there's another term that is older, but still used by many, and you'll hear it today, it's called hypogonadism. And that's the term that the FDA still prefers, but they're the same. Hypogonadism and testosterone deficiency. You're also going to hear testosterone therapy and another term, testosterone replacement therapy. Often we sometimes fall into our jargon of TRT, and those are also the same. So don't be fooled by that either. And then some useful information. The FDA defines a normal testosterone as between 300 and 1,000 nanograms per deciliter. And what that means practically is that when we talk about people who have low levels, in many of the studies, it means they have a testosterone that is less than 300. In Europe, interestingly, the lower cutoff to be considered to have low testosterone levels is a little bit more generous at 350. So in some ways, it's easier to be diagnosed with low testosterone levels in Europe and in much of the world than it is in the US. One other term that you may hear that's not on the slide is something called androgens. So androgens, and you're going to hear this from us too, androgens is a class of molecules, of which the best example is testosterone. All androgens have testosterone-like properties, but androgens refers to all of them, and testosterone is just sort of the shining example, if you will, of that. So I think that's the end of my introductory comments. I'm going to be giving the very first presentation. And so I don't need to be introduced again. So I'm just going to go right into it if you can bring up those slides. the most misunderstood molecule in medicine. It amazes me. I've been doing this, as you'll see, I've been doing the work with testosterone for more than 40 years, which really dates me. It's amazing to still be doing this. And part of what has motivated me over the years is just that to some extent, there has been this resistance to it. Let's go forward. So we have this paradox, and in essence, this is really why we're here today. And here's the paradox. We have the highest level evidence that can exist that testosterone therapy has important beneficial effects for some of the most critical healthcare issues that affect men and to some extent women in this country and around the world. You're going to hear talks today on obesity, on diabetes, on COVID, and there are a number of other important areas too that you won't hear anything about today just because we don't have time. For instance, osteoporosis, anemia, and even depression. Excellent data. Yet somehow within medicine, all these benefits around testosterone have gone almost completely unrecognized. And the question is, like, why? And some of you may be wondering right now, with a normal, healthy level of skepticism, you might say to yourself, well, if testosterone therapy is really so great, why would physicians ignore it? And there's the sense that physicians, especially academic and leaders, they're all open to whatever new information comes in and they adjust their thoughts and their ideas. And the truth is, it's just not so. And the reason is we're all human. And just like in politics, and I know there's some of you watching today who are in there, it's all about the narrative. Our brains are designed to pay attention to stories, and we look at things fit in the stories. And so when there's an election and two candidates start running, what's one of the first things they do is they try and define their opponent. Say Sleepy Joe, or somebody's tied to the oil and gas industry, so you can't trust anything he says. And if those narratives stick, it's very difficult to change it. And that's what's happened with testosterone. It's been around for a very long time. There's a narrative about it, and it's hard to change it. So if you don't believe me, it's a little experiment here. So if you see these three medications, like, what do you think of? Tadizolid, latanoprostene, istradefylline. My guess is you don't think about anything. It's just boring medical stuff. They're just medications, who knows, right? Especially if you're not working with them within medicine. But what about testosterone? Testosterone conjures up all this stuff that's got nothing to do with medicine. So maybe you think about bodybuilders, maybe you think about toxic masculinity and sexual predators. That's Weinstein there, the director. Maybe you think about athletes who are doping with the Tour de France or other things. But none of these have anything to do with the medical condition that we're talking with you about today, which is a deficiency of testosterone and its treatment. For those who are in medicine, there's an additional problem, which is not just the social or cultural ideas about testosterone, but it's really interesting what has happened. So testosterone was first synthesized in the mid-1930s. And by 1940, if you look at this timeline on the left, there was already an article in the New England Journal of Medicine, the most prominent medical journal in the world, that basically extolled the virtues of testosterone. Testosterone therapy is super. What happened the very next year is that a fellow who would later win the Nobel Prize did some research with prostate cancer and came out with the conclusion that testosterone activates or causes prostate cancer. And boom, that was the end of testosterone for the next 60 years. Everybody was afraid, certainly me in my training in the 1980s, that if we raised testosterone even a little bit, that we were putting men at risk for getting prostate cancer or making hidden cancer grow like crazy. Somewhere in the late 1990s, the very beginning of 2000, 2001, there was some enthusiasm as the evidence started coming in from research studies about the benefits of testosterone. And some of the research, including some of my own, if I may say so, started doubting this prostate cancer and testosterone link, there was this enthusiasm for men who had what was called then andropause. The idea was that it was somewhat akin to menopause, but for men. That testosterone levels, as they declined in middle-aged and older men, had these symptoms and these effects, and testosterone therapy, now there was starting to be some research in this, was showing benefits. 2001 was when Androgel, the first new branded testosterone, came in the last 25 years. And boom, what happened after that is that the Women's Health Initiative study, the WHI, was published in 2002. And it shattered this idea that hormones in women were helpful. And it was the largest media story in healthcare in the last 20 years. And today we know that the results of that were way overblown and that things are not as dangerous, but it took a long time to counter that media narrative. And then over time, we had more research showing the benefits of testosterone up to about 2013. A lot of research. Some of the folks on the panel here today were involved in some of this, very exciting. And at the end of 2013, again, boom, a huge media story based on a terrible paper, but in a prominent journal, was that testosterone caused heart attacks, strokes, and death. And I had cardiologists calling my patients, telling them, you have to get off testosterone, that thing's going to kill you. And that's what most doctors who are not in the field still know about testosterone, is they know the media story that testosterone was dangerous for the heart. So that's kind of what we're fighting. I'll just tell you how I got into this field briefly. And it's really, if you get this, you'll understand there's no real agenda here. So I was an undergraduate at Harvard, and I ended up working in a laboratory with the brilliant evolutionary biologist, David Cruz. And I worked with these lizards. You see them all over Florida, Anolis. This is a sexual display. They have this bright colored flap of skin that comes out. And if you castrate them, which removes their source of testosterone, they don't do any sexual behavior with the females. And then my project was put little bits of testosterone in their brains, even though they had no circulating testosterone. And it showed that when I was successful in putting in the right place, these men ended up, lizards ended up having their sexual behavior come back. And in medical school, we learned almost nothing about testosterone, except it was necessary for puberty in men, and it was dangerous for the prostate. That's what we learned. And when I came out of my training in urology, in 1988, and I started doing sexual medicine, amongst other things, we were stuck because we had very little to treat men with. Viagra wouldn't show up for another 10 years. And because of my lizard experience, I wondered, could men possibly be like lizards? And the answer is yes, they were. And I started treating some of these men. It wasn't something I was trained to do. I knew no colleagues who were doing it. And in addition to some of the sexual symptoms getting better, these men had very powerful stories that I had no idea that this would happen. They would say things like, my wife likes me again. I have more patience for my small children than I've ever had. One guy said, I wake up in the morning with optimism. I haven't felt that way in 10 years. And that's what motivated me to start doing it. But because of the prostate cancer story, I always wondered and was scared that we might be making a pact with the devil, that we're going to improve their quality of life, but that there was a cost to pay. But over the years, the research didn't show that. On the contrary, it was very reassuring. And you're going to hear about prostate cancer and testosterone from one of our speakers, Mokir, in a little while. And in the end, I started treating men who actually had metastatic prostate cancer with testosterone. If they wanted to. These men sought me out. And the traditional way we treat them is actually by lowering testosterone. And my training with the first guy who came to see me was that giving it to a man with bad prostate cancer that had spread throughout his body could kill him. And I said to him, this could kill you today, tomorrow, in a week. And what he said is, I want to do it. And he said, while I'm alive, I'd like to live as well as I can. And he was on it until he died about a year later, which was about his life expectancy at that time. But, within a few weeks, he started exercising. He started corresponding with his colleagues around the world. and he gained weight. He had a marvelous experience. It was something incredible. And the point is that these men were told that they could die if we gave them testosterone, and they still wanted to do it and maintained it. And so the paradox here is, how can the benefits of testosterone therapy be minor or considered minor if men are willing to risk their lives for it? So why does any of this matter? I think for the individuals, we see better quality of life and health at a higher level for insurance companies, corporations, government that pays for healthcare through the VA and Medicare and Medicaid. Better health actually means lower cost. And on a societal level, I think based on my clinical experience and those of others on this panel, for sure, what we would see with better awareness and potentially more treatment where indicated is increased creativity, production, and even kindness in our culture, and ultimately a better world. I'm going to end there.